are going to discuss the nucleus removal. As we know that the nucleus is the only part which needs the Phacoemulsification machine, and all other parts can be removed manually without any problem. So in a different scenario, how we are going to handle the nucleus, that is what we will be talking about. So I will be covering about the basics of nucleotomy. Dr. Ikeda will be covering how to handle the soft cataract, and she'll be also taking over as a posterior polar cataract. Then I'll be talking about hard cataract. Dr. Ashok Sraf will be taking on to the intumescent cataract. Dr. Anurag Mishra will be talking nucleus management in a small pupil, and Dr. Rajesh Sinha nucleus management in presence of the corneal opacity. Dr. Rajiv Chaudhary nucleus management in subluxation, and Dr. Tinku Bali nucleus management in presence of posterior capsular rupture. I'll start.
So first off, Dr. HARBANSH is going to speak on basic of nucleotomy. Dr. HARBANSH, please.
So I'll be talking about the basic facts whenever we want to remove the nucleus. This is our instruction course. These are the speakers. So there are certain anatomical facts which we need to keep in mind when we want to remove the nucleus. We need to understand the phaco machine and the choppers, nucleus removal techniques, steps and terminologies. So if you see the nucleus anatomy, nucleus is concave backwards. This is very important, and hardest part of the nucleus is not posterior most. It is nearly 3 feet to 2 feet junction, I mean more or less little below the center. And when you make a trench, you have got to make deeper into the center to crack it. So always remember that periphery is shallow, so you don't have to make a very deep trench in the periphery. You got to make deep trench in the center. Another is the all phacoemulsification have to be performed in the central safe zone, where there is a maximum volume available, where the cornea is convex upward and the capsule is concave backwards. If you try to do anything onto the peripheral part, which is mentioned right over here, and to the capsule of cornices, you may hold the iris or you may hold the capsule. So all the procedures have to be performed in central safe zone. And if you try to take your probe to the peripheral unsafe zone, you may catch something unwarranted. So how much the parameters should be, that depends upon, whenever we are trying to analyze, we need to understand how good is the cornea. That means suppose there is a endothelial dystrophy, probably you will like to do at a low parameter. If there is a corneal opacity, you will like to do at a low parameter. If anterior chamber depth is less, there is a less fluid inside, you will like to do at a low parameter. Pupil and iris, granules, lens and nucleus. If the nucleus is very hard, you will like to operate at a very high parameters. So all these things you have got to keep in mind when you try to set up your parameters. And then also it will depend upon the type of phaco machine you have. And a high-end machines, of course, you can keep very high settings, and experience and technique what you are going to use. So all these things have to be taken in consideration. And the holding power depends upon, we know that area is 3.14 into R square. That is the holding power. If you use a micro tip, holding power will be less. But if you use a wide bore tip, the holding power will be very high while the settings are the same. That means when I am operating a hard cataract, I will take a wide bore so that I can hold it strongly, I can chop it comfortably. When I am operating a soft cataract, I don't need a very big bore. And flow rate decides how fast the things will happen once the vacuum seal has happened. That means the tip is occluded, how fast the preset vacuum will be reached. But the vacuum is the one which decides the holding power. So we need to understand, when we call up a divide and conquer, we make it 2 cross, we trench once and then trench again. Then there is a chopping, a stop and chop, And steps are trenching, splitting, chopping, phacoaspiration. These are the certain terminology you need to understand. This is a divide and conquer image where you divide into 4 pieces. And this is a stop and chop. After divide and conquer came chopping. A stop and chop was invented after that. So the chopping is much faster. In a stop and chop, you make first trench, divide into 2. We call it a stop. When you started like a divide and conquer, then you stopped in the middle and went to do the chopping mode. When you do the chopping, we need to understand the terminology of vacuum seal. Vacuum seal means once you bury your tip with the energy inside, lift your foot to the only aspiration mode, and the tip holds at the tip. I mean, the nuclear fragment is at the tip. It is sealed. Tip is sealed by the vacuum suction. It is called a vacuum seal, so that its nuclear fragment is lollipop or held over there. Then chopping could be central or vertical. When you do within the rhexis margin, it is called central, and you are going down vertically downwards toward the vitreous cavity, which is central and vertical. Peripheral is when you start from the periphery of the nucleus and pull it towards the center of the nucleus, it is called peripheral. So to create a vacuum seal, nudge at the central part of the nucleus, bury with the burst of energy at foot pedal position 3, and then bring the foot pedal into the position 2 and keep on holding over there. So this is a peripheral chop where the chopper is negotiated under the rhexis margin horizontally, then made vertical and pulled towards the tip. This is a central chop where you bury the chopper directly within the rhexis margin. Thank you very much.
Now, I request Dr. Ikeda to speak on soft cataract and later on the posterior polar cataract. As we know that soft cataract and posterior polar cataract seems very simple, but there are sometimes they become the most difficult cases to deal with. So Dr. Ikeda is going to highlight the tips for that.
A very good morning to all of you. Can we have my slides, please? Yeah. So first, I'll be talking about phacoemulsification in soft cataract. The problems that we face are first, that the rhexis tends to run away. Secondly, during phacoemulsification, there is difficulty in achieving a good vacuum seal and therefore chopping, which leads to formation of a bowl and increases the risk of a posterior capsular rupture. Usually these are young patients with a very elastic capsule, and therefore forceps come in handy to complete the capsular rhexis. Let's talk about phacoemulsification. Usually when we are dealing with hard cataracts, we tend to operate at higher vacuums, and since the nucleus density is more, it is easier to hold them. Whereas for a soft cataracts, we tend to operate at lower vacuums, and the nucleus is less dense, and this leads to a poorer hold, and therefore we have difficulty in chopping. The second aspect is that the epinucleus tends to be a little sticky. It sticks to the nucleus, and we are unable to pull the nucleus towards the center and chop. These factors lead to us operating in the peripheral unsafe zone, that is the normal tendency, which increases the risk of posterior capsular rupture. So now let's look at a few surgical videos and understand different techniques which can help us in dealing with soft cataract. So our first patient here is actually posted for refractive lens exchange. She's a young 33-year-old high myopic patient. So we are using here the cystotome to complete the rhexis. Notice the size of the rhexis is quite adequate, 5.5 millimeter size rhexis, and we are just using the hydrodissection cannula here to prolapse one of the poles up. So this is the first technique. Use the hydrodissection wave if you have a decently sized rhexis, prolapse one of the poles up, and this makes our job very easy, and we can now emulsify with ease. These cataracts are very soft, so we are not going to use too much energy, which could be damaging to the endothelium. Now, since I'm having a little bit of difficulty in getting this subincisional part of nucleus up, I'm going in again, injecting a little bit of viscoelastic and again prolapsing it up and then emulsifying it safely with ease, hardly using any energy, purely vacuum settings. And then we go ahead with the rest of the steps, remove the cortex and implant the IOL inside the eye. Now let's look at another case. This patient has a grade 1 to 2 cataract, not as soft as the first case. And this, if you don't have a very large rhexis or the nucleus is not extremely soft, this is the second technique that I want to highlight. What we are doing here is, first we have done a very good hydrodelineation to free up the nucleus from the epinucleus. And then we are rotating this lens all around and aspirating this anterior epinuclear plate so that we have easier and better access to the nucleus. So we are going all around in all directions, and then we are simply just putting a chopper behind the nucleus and prolapsing this nucleus up with the help of chopper. So this, because we have removed the anterior epinucleus, maneuver becomes very easy. If the anterior epinucleus was sticking to the nucleus, we would find this a little bit more difficult. And we can go ahead and then emulsify this nucleus with ease. So this is the second technique that we can employ for these cases. Now let's look at another technique. If none of these techniques we have planned, or we don't want to do this and we want to go ahead with the traditional technique, then what we can do. So again, a good hydrodissection and a good hydrodelineation I feel is very important for soft cataracts. When we are going ahead and removing the anterior epinucleus again to free up the nucleus, just rotating and going ahead. Now, I will demonstrate in this case the technique of stop and chop. So here the trench that we need is not very wide and not very deep, because these cataracts are soft. So you don't want to create a very deep or a very broad trench. We just need a small shallow trench, and once we have created that, we are going ahead with just horizontal chop. So horizontal chop is good enough and gives us a good hold, as well as helps us in aspirating these pieces very safely. So we can use this technique when none of the other two techniques we want to go ahead with, or if the rhexis size is not adequate, then we can emulsify and then do a horizontal chop and rotate the other part of the nucleus and then grab onto it and emulsify. Now, let's look at this last video for soft cataract. This case highlights some of the difficulties that we face associated with soft cataract. So, after making a trench, we crack the nucleus and we have divided into two segments. And now I'm rotating this and starting with my chopping. Now we notice here that as soon as I try to chop, part of the nucleus keeps coming into my phaco probe and I'm unable to achieve a hold. And this is what typically happens when we are stuck in a situation like this and we end up creating a bowl. So how do we get out of it? What do we do now? So we have to increase our vacuum settings and keep a very low power, because if we increase the power, we are just going to splice through and we won't be able to hold it. So reduce the power, increase the vacuum, operate at a moderate amount of vacuum, and slowly and consistently pull on one of the poles of the nucleus. And then one of the poles would prolapse out, and then we can easily take care of this nucleus. So the tip here is to do not decrease the vacuum to such a level that we are unable to aspirate, but decrease the power so that we don't splice through. And once one piece comes off and we are able to prolapse one of the halves of the nucleus, the other one becomes very easy. So to summarize, the techniques discussed for soft cataract here are: first was the prolapse one of the poles of the nucleus with hydrodissection and emulsify. This is useful if you have a decent sized rhexis and a very soft cataract, a young patient. The second would be to remove the sticky anterior epinucleus after a good hydrodelineation. Then either prolapse the nucleus in toto and emulsify, or you could use chop or stop and chop, one of these two techniques, whatever you're comfortable with. If you have formation of a bowl and you're unable to get out of that situation, then the way to move forward is first to look at your settings, decrease the amount of power and keep a moderate amount of vacuum, and slowly and gently keep holding one of the poles slightly anterior, not too deep, and then you would find that one of the poles comes up and you're able to complete the case safely. Thank you. So I think I'll go ahead with my second talk, or should we, if we have any questions, we can take regarding the soft cataract now. Otherwise, I can move on and then we can have a discussion in the end. Right, so let's look at posterior polar cataracts now. So, posterior polar cataracts also tend to be soft. My first patient here is that he has nuclear sclerosis. When in a high hypermetropic patient, we can see the IOL power is 36 diopters along with the pterygium. And the anterior chamber depth here, or the aqueous depth, is adequate, 3.03. This is something we have to look at when we are operating high hypermetropes. And the astigmatism is less than 1 diopter, and that's the reason why we are not taking this patient up directly first for pterygium surgery. This patient wanted only visual rehabilitation, so we are not addressing the pterygium here. We are going ahead with cataract surgery. So the first tip here regarding the capsulorhexis would be to have an adequate size capsulorhexis, 5 to 5.5 millimeter, not too large, just in case we have an inadvertent posterior capsular rupture and we need to plan an IOL in the sulcus with optic capture. That would make it hard for us if we have a very large rhexis. Now we are taking a viscodissection cannula. I like to do this technique of limited viscodissection. So we are injecting very little amount of a dispersive OVD under the anterior lens capsule and then going ahead with hydrodelineation. So before hydrodelineation, we just inject a little bit of OVD under the lens capsule. This serves one major purpose, that is that it prevents inadvertent hydrodissection during hydrodelineation, because the viscoelastic substance provides a little bit of resistance. So we do not end up doing an inadvertent hydrodissection. Then this patient has a nucleus sclerosis of grade 2, so we are going ahead with creating our trench. Now we have to be a little gentle and avoid putting too much pressure. Any maneuver that would cause a lot of pressure to the posterior capsule needs to be avoided. So another tip here would be that once we have cracked this nucleus, just nudge the nucleus and chop. Do not try to rotate the nucleus very vigorously, because these rotating maneuvers itself can put stress on the posterior capsule. So we have nudged one of the segments of the nucleus and prolapsed it, and then we are going ahead with the chopping. As most of the posterior polar cataracts that we would come across would not be very hard, as the patients present earlier to us. So we are not dealing with very hard cataracts here. So we can see that the nucleus has been prolapsed. Another important point to remember is that whenever you come out of the eye, before we come out, we always have to maintain the space and do not let the chamber prolapse. Then I'm doing a viscoprolapse technique of the epinucleus here. I'm injecting viscoelastic under the epinucleus, and this serves two purposes. One, it makes it very easy for me to aspirate the epinucleus, and second, if we have had a PCR, it would plug that dehiscence over there, so it makes it a little safer for us and keeps the chamber formed. And we can see here now that the posterior capsular opacification has come out with the posterior epinucleus, and we are going ahead with irrigation aspiration. Another tip for irrigation aspiration is try not to be too tempted to clean and polish the posterior capsule very vigorously in these patients, because even if you don't have a rupture, they have a very fragile capsule which can give away. We are implanting a 36 diopter single piece hydrophobic acrylic IOL inside the bag, and after cleaning up the viscoelastic, again before we come out, we are injecting an air bubble to avoid a chamber prolapse. Now this is the left eye of the same patient, and we have taken this up for surgery now. I'm going ahead with the technique of limited viscodissection and then aspirating the anterior epinucleus, following the same rules as we have discussed. As we all know, hydrodissection is a contraindicated step for posterior polar cataracts. So here the nucleus is a little softer than the right eye. So as soon as we start creating the trench, we can just prolapse this nucleus up, and this can be emulsified. So again, in this also I would like to highlight that I have approached it like a soft cataract. I have aspirated significant amounts of anterior epinucleus so that I have better access to the nucleus. And this is the end of our nucleotomy. We follow the same principles and aspirate the epinuclear plate, and this is the end of the case. Now I'd like to share a case where we had a posterior capsular rupture. So this we need to be prepared for mentally and inform the patient beforehand. Whenever we are operating posterior polar cataracts, there is a small chance that we might need to change the IOL, and you might have a posterior capsular rupture, and the implication of the same to the patient. So we have started this case similarly, taking all the precautions, and this is again, we can see a very soft nucleus with a significant amount of posterior polar cataract in this case. And everything seems to be stable. We are aspirating the nucleus. I've followed the technique of stop and chop here. And again, injecting the dispersive OVD before coming out, and I'm injecting some dispersive OVD under the posterior epinucleus before aspirating the epinuclear sheet. And we notice here, I realize that as soon as I aspirate the posterior epinucleus, that the posterior capsule is not intact, and we have a dehiscence here. So first thing we need to do is be calm and just inject viscoelastic with the left hand, keeping the phaco probe inside the eye. So here we can see that there is a posterior capsular rupture. Then we go ahead with vitrectomy, and because I don't want to operate with vitreous in the eye, and there is a lot of cortex still remaining inside, and the whole of the cortex need to be aspirated. So my technique here is to first do a vitrectomy, and then I'll switch over to irrigation aspiration, bimanual irrigation aspiration, once I'm sure that there is no vitreous inside the eye, since this gives us better access in dealing with so much of leftover cortex, although vitrectomy cutter can also be used for the same. So first I'm starting with the areas where there is no posterior capsular rupture, where the PC is intact, and then slowly moving to the areas where there is a posterior capsular rupture. So before we go ahead and aspirate the cortex very close to the posterior capsular blowout, we are going ahead with our vitrectomy cutter again, and this leftover cortex I'm using the vitrectomy cutter to aspirate. And then we are placing a 3-piece IOL in the sulcus here. We have changed our plans and decided to place a 3-piece IOL in the sulcus because there is quite a large posterior capsular rupture, so we do not want the IOL to be unstable later on. So the haptics have to be tucked in under the iris and making sure that the lens is stable. We can even inject triamcinolone at this point to make sure that there is no vitreous remaining in the anterior chamber before we close the case. So I'm removing the viscoelastic with the vitrectomy cutter here, and before we end the case. And usually even the presence of a round central air bubble, a round central pupil, gives us a very good idea that there is no vitreous remaining in the anterior chamber. Thank you.
Thank you, Gita. We will have discussion after the talks. Now I invite Dr. HARBANSH to speak on the Phacoin heart cataracts. Going to highlight some special tips for managing the heart cataract.
AIOC2023 का slide आपका देखा आपने?
Today I am going to talk about how
I should have changed this.
Today I am going to talk about how to operate heart cataract with average skill and excellent understanding of the biomechanics. While operating heart cataracts, certain anatomical facts are to be kept in mind. The central part of the nucleus is densest, thickest and deepest. It is concave backwards, and most of these cataracts have posterior leathery plate. To manage these challenges, I am going to demonstrate my technique of V-trench, rotational separation and radial split. For this, I will recommend using long and short chopper designed by my dear friend Dr. Mohan Rajan and Kelman tip for ease of trenching. Now I will explain what is V-trench. We make trench which is horizontally and vertically in the shape of V as shown in the diagram. Horizontally to accommodate the sleeve of the phaco tip and vertically to reach to the depth of the central nucleus. Now watch the video. Peribulbar block has been given. Temporal limbal incision has been made. Capsulorhexis is being made larger nasally and on the left side. This is the area where most of the chopping, splitting and crushing of the nuclear fragment is going to take place. This prevents inadvertent damage to the capsulorhexis margin and collapse of the nucleus into the anterior chamber. No hydro procedure has been done at this stage. This gives excellent stability of the nucleus for trenching. To make a pattern of V, start trenching paracentrally to have a wider trench at the periphery. The speed of the tip movement, energy delivered and depth sculpted should be such that there is no pushing of the nucleus and no cavitation bubble formation. If you are pushing the nucleus, that means energy delivered is less. If there is a cavitation bubble formation, that means energy delivered is much more than needed. Now sculpt more in the center to have vertical V trench. After withdrawing the chopper, we inject the viscoelastic and then withdraw the probe
to prevent the shallowing of the anterior chamber. Now we will perform gentle hydrodissection before rotating the nucleus. Hydrodelineation is not needed. Keep the chopper at the periphery of the trench and rotate the nucleus. Now look how wide peripheral part accommodates the tip and sleeve comfortably to deepen the trench in the center. After adequate trenching, we split the nucleus. Nucleus has been divided into two parts, but posterior leathery plate is holding on. Now I will demonstrate my technique of rotational separation and radial split. Bury the phaco tip at the peripheral end of the heminucleus. Hold it firmly with high vacuum setting of 600 mm mercury. Hold second heminucleus at the periphery with chopper and start rotating. You can see nice radial split taking place. Once it reaches the center, stop it. Now we will rotate the nucleus and repeat the rotational separation and radial split to divide the leathery plate into two. When you try to separate the leathery plate by lateral separation, you are trying to tear too many fibers in one go, requiring much higher force. Not holding the nucleus with the phaco tip makes it unstable and you put too much of pressure onto the posterior capsule and granules. While you use my technique of radial separation, you are holding and lifting the nucleus and there is no pressure on the capsule or granules. At the same time, using a radial split, you are tearing one fiber at a time, requiring much less energy. Now we come to second part of the surgery, what is called phacoaspiration. Hold the heminucleus deeper and at the densest part with high vacuum setting of 600 mm of mercury. Place the long and sharp chopper within the CCC margin adjacent to the tip. Bury it, move it laterally to split. Keep on repositioning the chopper closer to the fibers you want to split. Separated nuclear fragment should be as small as possible. They should be further broken mechanically by chopper. This improves the flowability of the fragment and prevents inadvertent damage to corneal endothelium. Use the combination of lateral and radial separation to tear the leathery fibers. Now we come to the removal of the second half of the nucleus. In this, I use modified peripheral chop, whereby I pull the periphery of the nucleus out of the rhexis margin and start the chopping. Combination of the lateral and rotational separation is used to break the leathery fibers. And nucleus is crushed mechanically and emulsified. Now most of the nucleus has been emulsified. We need to take extra precaution because the posterior capsule can move forward. Now we are going to remove our chopper. We inject viscoelastic to push the posterior capsule back. Reduce the vacuum setting to 500 and change the chopper from sharp and long to blunt and short. Now we have come to the removal of the last fragment, and this time posterior capsule and cornea, both of them are highly vulnerable. We lower the vacuum setting to 400 and use the chopper to keep the fragment in front of the tip and away from the cornea. That rhexis is larger nasally and onto the left hand side. Day 1, patient had absolutely clear cornea and 6/9 vision.
Thank you. Thank you, Dr. Harbansh. The nice presentation on hard cataract. Now I invite Dr. Ashok Shroff to speak on white intumescent cataract.
Good morning, friends. At the outset, I thank Dr. HARBANSH Lal and the scientific committee to allow me to share my views, allow me to make my presentation, how to handle the white intumescent cataract. The intumescent white cataract is a morphological diagnosis. The cortex here is swells up. EC becomes a little shallow, and the intralenticular pressure becomes high. The important is to take the precautions during the surgery to make sure that the rhexis doesn't extend because of the high intralenticular pressure. And you can see that sometimes if you don't take precautions, you can see that the EC is just trying to make the rhexis and it splits. So this is very important. And then there are methods how to debulk the pressure. The options we have is either you do the YAG capsulotomy before about 30 minutes, or you make the puncture in the anterior capsule and allow to escape the milky fluid. Then is the Mohan Rajan technique. Then we have, of course, it is not our own technique, but then we have little modified, and you can do the small rhexis initially, orange peel technique, and then you do the nucleotomy. You can see here, just make a very small opening in the capsule and allow the milky fluid to go out, escape out of the chamber, and the pressure becomes low, and then you can proceed further. Then here you have to use the Venturi system, and is a 0-degree tip, a very high vacuum, and put it in the center, and vacuum is about 500, and you can see that not only the cortex is sucked, but there is a little pit in the lens matter also. And then you can proceed further and make the rhexis. This is what our technique, what we do, that we introduce this 21 gauge needle, ½ inch, and we hold the eye, and I allow my assistant to withdraw the plunger, and you can see here the fluid cortex is being gradually aspirated, and so it debulks very nicely. And then you can go ahead and do the rhexis. The phaco procedure here, you know that this is very scanty, peripheral cortex is very less. There is no epinucleus, no need for hydro. It's a routine phaco with the low parameters. But however, we have to be very careful during to avoid the PCR. Is a male, 48 years. You can see the fluid cortex is being aspirated just to debulk the pressure. And once it is done, need not worry about even the rhexis to start with little irregular. You can regularize it later on gradually. Only thing you have to make sure that it doesn't extend. And once it is done, when it is completed, after, you can do if you want, it doesn't rotate easily, but it easily rotates. And then make a gutter, and with the sharp chopper, you can see here is a sharp chopper, and then it's easier because the cataract is a little soft. And then, but you have to make sure that you don't cut or don't injure the rhexis margin. And then you bring out into the center, and then do the phaco and aspirate and remove the nucleus fragments. There is another case where the rhexis is, it is a corneoscleral incision because of the charity case, and we wanted to go for the rigid lens. So the incision has been put here. And you can see here, once you make the trench, see reverse chopping, and then rotate the half of the nucleus, make another fragments, and then remove it. Here you can use the low parameters, depends which machine you are using. And then if necessary, either you can decrease still further all parameters, the vacuum as well as the power. But make sure that the lens fragment don't come in contact too much in the corneal endothelium, otherwise it will damage it. There is an orange pill technique where we initially make the small rhexis. It's a reverse rhexis, just to make sure that it doesn't extend. Sorry, just 1 minute. Again, easy. Only make sure that because the rhexis is small, you have to be very sure that you are within the rhexis area and at the iris level. And here, if necessary, bring it in the little antechamber, but see that the rhexis is not damaged. And then you can enlarge the rhexis. Thank you very much.
Dr. Rajas Sinha has to go for his suction course, so we'll be taking up his talk first. He'll be talking about the nucleus management in presence of the corneal opacity.
Very good morning to all of you. Thank you, sir, for having me in this wonderful course. And I'll be presenting to you about how to manage cataracts when you have a associated corneal opacity or haze. And normally when you have a corneal opacity or haze along with cataract, the most optimal and the best management option is a corneal triple procedure, wherein you do a keratoplasty and then you do a cataract surgery, put an IOL, and this is how it looks like. But in some cases, in quite a good number of cases, these patients have a bad corneal opacity, haze, have vascularization, risk of rejection, they can't come for follow-up. In all these cases, and particularly when you have an opacity which is not covering the whole of cornea, and the other eye is thusical, so there are situations wherein you just feel like doing only cataract surgery and provide some reasonably good vision in these patients for the rest of their life without the risk of any graft rejection or loss of follow-up or graft infection. The biggest issue in these cases is poor visualization because of corneal opacity and haze. And what we would like to discuss in this presentation is to discuss methods or techniques to enhance visualization in these cases. So one of the most important prerequisite is a well-dilated pupil, and as we all do surgeries under topical anesthesia, but if there is any corneo iridic adhesion, etc., and if you have to do any manipulation in the iris, then in such cases we may do it under a block. It can be a peribulbar or subtenon block. We have been using trap-and blue dye for quite more than 2 decades now. 2.5 decades, and these are used in white corneas. But in cases of corneal opacity or haze, it should be used for a slightly longer period so that you can stain the anterior capsule nicely, not only for doing the capsular rhexis, but also to ensure that you don't chop off the margin of the rhexis while you are chopping the nucleus, because the visibility is not that great. Another important issue is that when you are doing a capsular excess, in a case wherein you have an opacity something like this, then when you are holding the capsular flap, don't leave it behind the opacity. Leave it in the area where the cornea is clearer, so that you can hold it appropriately and complete the excess and go ahead and do the procedure. And then, of course, the other things, the nice hydro and chopping, etc., should be done to complete the procedure. Another important thing is use of, say, methyl cellulose over the cornea. What happens that if there is any haze, then if you suddenly put a methyl cellulose over the cornea, the visibility improves at that moment. As you can see, the moment methyl cellulose is put over the cornea, the visibility improves. If you are doing any crucial procedure, something like chopping, etc., in order to see better, put methyl cellulose over the cornea, ask your assistant to do it, and that improves visualization, and you can go ahead and complete the procedure. Viscoelastic, again, a good quality viscoelastic in the anterior chamber, which includes chondroitin sulfate, so that it coats the endothelium, so that it doesn't damage the endothelium more as it is already damaged. And of course, use of methyl cellulose like viscoelastic over the corneal surface is very helpful. An opacity like this you can manage with a pupil size of 5-6 millimeters, but a case wherein you have a very hard cataract, a black cataract with a central opacity, in such cases it is always better to enlarge the pupil as much as possible to have better visualization. We have described a method of eccentric crater and chop. It shouldn't be peripheral, it should be just slightly eccentric, so that you can chop it under direct visualization. Another important method to improve visualization is the use of endoilluminator. The endoilluminator, which is so often, every time used in the retinal procedure, can be used to improve visualization in a cataract surgery. When you are doing nuclear chopping, the endoilluminator should be placed over the cornea, so that the visibility is better. An assistant can hold it and you can complete the chopping procedure. But once the chopping is complete and you have to remove the epinuclear plate, the endoilluminator should be taken inside in the anterior chamber, and thereby you can hold the epinuclear plate carefully without causing any damage to the capsule, to the anterior capsule or the posterior capsule. And this is how it improves visualization, and you can complete the procedure. Another important method to improve visualization is the use of chandelier illumination. In a case of a hazy cornea, you can put chandelier illumination, you can get a very nice glow, and you can do a nice rhexis and all the nuclear procedure, etc. you can complete with the help of a chandelier illumination. If you have a opacity which is not completely obscuring, it is obscuring part of the pupil and it's on one side, in such cases you can do a cataract surgery, place an intraocular lens and do small sphincterotomies. Earlier in opacities, optical iridectomy used to be done, but it should not be done in cases wherein you are doing a cataract surgery, because then you will have aphakic and pseudophakic zones. So just do a small sphincterotomies, and that helps, because this part acts as the new pupil and this is obscured by the opacity, and this study we published in the year 2004. So in conclusion, nucleus management in eyes with corneal opacity is challenging. We do have to understand how to improve visualization. There are various methods: use of OVD, use of trap and blue dye for long period, use of endoilluminator, chandelier illumination, and all these methods are utilized to improve the outcome by improving visualization. So thank you very much for your patient listening.
Thank you, Dr. Rajesh Sinha. Have you ever did ACC or SICS in cases of dense corneal opacity?
Yeah. Yes, that's true. We do. I mean, SICS is a good option in these cases wherein you have a dense opacity. That's a good option.
Recently, I had one patient, very elderly, with TRABI operated with dense cataract, corneal opacity, just PLPR. So I actually went for the, IC depth was just 2 mm. So I just went and did the ECC.
Yeah.
So that we wanted at least patient should have whatever vision possible. So if there is too many complications associated, if phaco is not possible, it's a not bad option to learn extracapsular cataract
yeah.
resection to remove the nucleus RSICS.
Actually, it's a very good option because that will provide a reasonably good vision for the rest of the life. So definitely without causing any damage to the endothelium by using excessive phaco or doing phaco in the anterior chamber, ECC or SICS is a good option.
Thank you, Dr. Rajesh.
Thank you,
He has to leave actually because he has got his own instructor course running.
Can I share one sentence? See, what sometimes the chandelier where you have to go to the pars plana, maybe for anterior segment surgeon it may be difficult, but these epsilon people they can make for you the illuminated chopper. So you have the illumination in the chamber as well as you can chop the nucleus. You can inquire from the epsilon. No financial interest.
So now we have got the Dr. Anurag Mishra. He'll be talking about nucleus management in presence of a small pupil.
Thank you so much, sir. Good morning, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. In the current platform of the advanced phaco machines in the industry, certain equipments to dilate the pupil properly, and of course, not to mention the surgeon's skills, the small pupil has ceased to become a menace anymore. It is actually very, very naive in these days. However, it's our job to go through the small pupil, so let's take a closer look. The surgical manifestations of a small pupil are these. It disturbs the geometry, so there's reduced access to the surgical area. There's increased permeability of the blood-aqueous barrier, but that's thanks to the conditions which lead to a small pupil. Trauma to the tissues is likely because the iris, the pupillary margin are very closely located to the phaco needle. You're likely to have a smaller capsular opening because the axis is less. Retained lens matter because the iris forms a diaphragm under which the shattered lens matters can be hidden. And of course, if you are trying a toric IOL placement, the alignment could be difficult in a small pupil. The causes for which we have small pupils and the mechanisms which cause them are, in a pseudo-exfoliation syndrome, we know that the dilator and the sphincter muscles deposits happen, which lead to atrophy of the tissues ultimately. In IFIS, there is a dilator muscle atony, which leads to atrophy again. Synechial membranes, they cause a mechanical restraint and prevent the pupil from dilating. It could be age-related because the tissue atrophy there is generalized. And then there's diabetes, which often leads to metabolic changes and causes a small rigid pupil also. The resurrections, preoperative NSAIDs actually prevent intraoperative meiosis. They do not do anything to dilate the pupil any further. Intraoperative agents like the phenocaine that has come up recently can, but very limitedly so, particularly in the setting of a rigid pupil. Superviscous OVDs can mechanically dilate the pupil. Of course, it stays for a very short while and gets washed off in a bolus once you go in with the aspiration on. Expander devices, there are many, we'll talk about them, take a closer look at them in a while. And of course, cyclitic membrane, if it is there on the pupil, it has to be peeled off. So let's see how that works first. This is a case of long-term iridocyclitis. You look at the pupil, and I'm trying to punch a hole through the cyclitic membrane, through the side port. The membrane has to be peeled off. So I'm trying to do a pupilloplasty, a stretch pupilloplasty first, so that it gives me access to the membrane, and then the tags of the membrane have to be peeled off, just like you do a rhexis by pulling on them tangentially. Invariably, these cyclitic membranes, when they are peeled off, they bleed, and it is good that they bleed. It's a sure shot sign that they have been severed from the pupillary margin successfully. It does three things. One, it brings the geometry back, as in this case. In the next case, the cyclitic membrane peeling is little more difficult because this membrane looks tough. These membranes always look tough. So if you look at the color, the blacker the membrane is, the darker the membrane is, the easier it is to pull. The whiter the membrane is, more difficult to pull. So there's one tag of membrane out here which is actually not coming out, and the membrane has the pupillary margin still not started bleeding. Now it started bleeding. So you know that we have severed it on one end. Then we go in, induce some viscoelastic. Then we try to tug in again, tangential force, right opposite. You have to take care that the iris does not put too much of stress at the root, because then the ciliary body will start bleeding and it causes disturbing hyphema. Ultimately, it comes off. This patient, after dilatation, the pupil expands to sufficient sizes. Then is your choice whether or not you're trying to or you want to put in a pupil expansion device. In some other cases, like you see here, once you do all this hydrocolysis and peel off the membrane successfully, which is minimal right at the pupillary margin, you peel off that, the pupillary margin starts bleeding, which tells you, and then the pupil dilates to enough proportions. This case will definitely not need any pupil expansion devices. So it's important for us to sever that membrane, and once you have a dilated pupil, the nucleus management is not going to be difficult. If you trying to put in iris hooks to dilate the pupil, then the side port has to be parallel to the iris. However, a lot of us have completely stopped using iris hooks for pupillary dilatation, except in a few specific cases. But if you're trying to use them, remember that at none of the angles the iris should be overstretched, because you want to keep the circular geometry even in the post-operative period. It's optional whether you want to put a fifth hook. I never put a fifth hook, but you can if you wish to. This is a Mulligan ring, which works the best in my hands, at least. The beautiful part of this ring is that the distance scroll engages right away. The side scrolls also engage as they come out. There's a bit of learning curve how to put this, and the proximal scroll has to be kept in the left-hand instrument engaged, and then the pupillary margin can be embedded in the same setting. The advantage that the Mulligan ring offers is it keeps the geometry intact and it does not cause microsphincter tears in the post-operative period. This is a Gupta's ring, which looks like the Mulligan in many senses. Both of them are made up of 5-0 polypropylene, but this goes into a 2.8 millimeter section. It does not go through a 2.2. It is slightly more difficult to engage the scrolls than in the pupillary margin than the Mulligan, but it works well and it's more economical to use because you can use them multiple number of times. Of course, with each autoclave, the scroll somehow loses its elasticity and becomes progressively more and more difficult. The Mulligan renders the pupil more diamond-shaped or more pentagon-shaped, and the Gupta's renders it square. This is our very own innovation, the B-Hex, coming in from Dr. Shubhen at Kolkata. This is a 9-0 nylon ring which can easily go through even a side port incision. He recommends a 23 gauge forceps to engage the alternate flanges underneath the iris surface. You can also use a Sinskey hook to do the same. It also renders the pupil in a pentagon shape and dilates the pupil if it's not too rigid, of course. Now, if you have a toric IOL situation, toric IOL situation, after implantation, you might just plan to remove the device under cover of BSS. You would not like to use viscoelastic in this. The Mulligan can come out through under cover of BSS. Of course, the second instrument plays a very pivotal role, which is the irrigation cannula in this case. You have to dab the side scroll so that they go in, and then counter pressure distally just to disengage the distal scroll. Now, all this is regarding the dilatation of the pupil. The proper nucleus management comes when you do not want to dilate the pupil. This is an example where the pupil is small, the cataract is hard, and I decide not to use any pupillary device. This is where the take-home pearls are. So the pearls are, you have to stay right at the middle. You have to ensure that the posterior plate is cracking and the crack is the chop is complete, and then you have to keep on rotating it. What I do normally in situations like this is I crack and absorb. So I don't complete my chops. I chop one heminucleus, then start emulsifying the heminuclei one by one. And as I advance, I keep on separating the piece from its adjacent attachment, and then keep on aspirating the diamond pieces or the pies that I thereby produce. Every time the apex of the nucleus is caught, every time you have to bring it to the middle to consume the remainder of it, because that's the safe area, as has been very nicely outlined by my previous speakers. This is an unedited video. This doesn't take too much of time, and you don't need to change anything in the phaco-perimeters. Look at the IOP. I operate under IOP of 20. Even then, there is no danger of catching the pupillary margin because I am operating in the safe zone and I trust my machine to produce a stable fluidics. Before I conclude, I'll just take 10 seconds extra. This is not pertaining to this particular segment, but when you have a very small pupil and you have the IOL implantation in question after the end of nucleus management, you don't really need to dilate the pupil anymore. The small pupil can also accommodate the IOL. This is the way how I do it under the cover of BSS. The advancing haptic is first fed into the bag. This is how I do it. The advancing haptic is used to be fed into the bag and then use the IOL optic to stretch the pupil for some time while the second instrument goes through the other side port. We know that we have a tilted IOL here, half in and half out of the bag. That makes our job easy to dial the remainder of it in, all under cover of BSS. We don't need to use viscoelastic or any pupil expansion devices just to do this job of ours towards the end of the surgery. Thank you so much for your attention. Thank you for the opportunity, sir.
Thank you, Dr. Anurag. We'll be discussing all the cases after the end of the presentation. And any one of you have got any questions, please be ready with that. We'll be more than happy to answer your questions. Otherwise, I'll be asking the questions. Now, our next speaker is Dr. Rajiv Chaudhary, and he'll be talking about nucleus management in presence of subluxated cataract.
Good morning.
So primarily focus on nucleus management.
Good morning, friends. So my topic is on subluxated cataract, and the management will depend on the extent of the zonular dialysis. And this is a real challenge for ophthalmic surgeon. And mainly, if you have to manage the nucleus, it needs comprehensive preoperative evaluation, and you have to assess the area of weak zonular and the presence of vitreous in the antechamber. So you can summarize that the extent, whether you can do with the hooks, whether we need CTR, we have to use the CTR, or you may later on need the scleral fixated lens, glue diol, iris claw. It depends on the extent of your subluxation. So it is we are showing the video, mild subluxated, only no CTR is used, we can manage. Start the rexis at the side of away from the area of zonular dialysis, good viscoelastic, and rexis from away from the zonular dialysis, so to avoid the stretch on the zonules. And once it is managed, you have to cover that area of zonular dialysis with the good viscoelastic, so to avoid the fall of the nuclear fragment in the vitreous cavity, and keep the chamber stable, avoid the fluctuation in the antechamber, otherwise it will increase your subluxation. And once it is done, you can put the lens at a haptic in the direction of the zonular dialysis. It will work as your CTR. Just place the CTR. It is more than 3 to 5 o'clock covers, more than this. Use the CTR. You can place the CTR before the nucleus management, or you can do in the late hours after the management. Once it is done, you can put the lens. Only the thing that you should avoid the chamber fluctuation, and you can continue the surgery. In this, there is excited, we have to use there is a large subluxation here, hard cataract, brown, doing with the staining, rexis slightly eccentric. Use the viscoelastic, hydration, hydrodissection gentle, try to manage the nucleus. Then we use the capsular hook to stabilize the bag. So bag is stabilized with the capsular hook. So it gives the stability of the bag during the phacoemulsification, and once the bag is stable, you can do the surgery very well. And later on, you can suture this CTR and put the intraocular lens. Suture the CTR, making the scleral flap. And remove the hook. And sometimes it is an extremely loose cataract. Then you have the option to use removing the nucleus. You have the option to use scleral fixated, glued IOL and iris claw. I am going to show you the iris claw. It is a congenital subluxated cataract. Doing the lensectomy, as because it's extreme. Here is the important, using the viscoelastic, good viscot, so that that fragment does not fall into the posterior chamber. Once you remove this with the cutter, making a 2.2 incision, later on it has to be enlarged because we are going to put the iris claw. I am going to show you the iris claw lens. Once done the anti-vitrectomy also, put the pilocarpine, two-side port. This is the iris claw. We are going to retrofix. The important thing is holding up the iris claw. Which claw you are going to enclave, hold from that side and hold firmly so that it can resist the pressure of that. And it is so simple, and especially in the complicated cases or subluxated small iridectomy. Another importance is use of this femto laser. The advantage of the femto laser in making is the importance is the making a capsular rexis, because in the subluxated, it's just 15 seconds video, subluxated cataract, making the rexis is difficult, because when you are going to make the rexis, it will giving a more stretch on the jonules and increasing. So with the help of the femto laser, you can make a rexis eccentric as exactly centering on the nucleus, and once it is done, you can do the surgery, remove the cortical soft cataract and suture the ring. Because the capsular site, we have the good capsular axis with the help of the femto, making a scleral flap, suturing the CTR. I am just fast forwarding. And making, this is the one of the great advantage of the femto laser by doing the rexis in subluxated cataract, and you can try to put the lens in the bag, or you can put, once your capsular bag is in position, you can put in the bag or in the sulcus or over the capsular. So in short, recent advanced equipment, it gives a better understanding of fluidics, relative safe cataract surgery even in subluxated cataract. Thank you friends.
Thank you, Dr. Rajiv Chaudhary. Now I invite Dr. Tinku Bali. She'll be talking about nucleus management in presence of posterior capsular rupture.
Hello, good morning everyone. So I'll be giving you an overview about management of PCT when it happens. Well, the first thing to remember is not to panic, but to organize your thought, your instruments, your staff, and get a hold of the situation. The goals of management are to avoid losing the lens, to remove all the accessible lens material, if necessary, perform a proper vitrectomy, and to avoid enlarging the capsular opening and to prevent capsular support. Well, as in all battles, when faced with a threat, do not stop, but do not retreat. So do not panic and suddenly withdraw your phacoprobe. Because hypotony is the #1 enemy whenever a PCT occurs. A PC tear does not equal an anterior hyaloid phase rupture. When you reflexively withdraw your phaco instrument, it ruptures the anterior hyaloid phase, as is shown in these diagrams. So the moment you withdraw your probe, this vitreous comes forward. Instead, you should put in a viscoelastic and then gradually remove your phaco instrument, as I'll be showing in this video. So here you see this, there's a PCT which is quite apparent. So the surgeon does not withdraw the phacoprobe. You go to the side port and you inject a viscoelastic. This way your vitreous face is stable, the vitreous does not come forward, and only after you've pressurized the anterior chamber with viscoelastic do you withdraw your phacoprobe. So that is the number one point whenever you have a PCT. The anterior vitrectomy that needs to be done has to be done in a closed system. So whenever, before starting anterior vitrectomy, do suture the main wound. Always do a bimanual anterior vitrectomy. Remove the vitreous before you remove the lens fragments, otherwise your vitreous will get captured into your phacoprobe. Use a high cut rate and a low vacuum when doing your vitrectomy, and use the cut IA mode. So as I mentioned, always use a closed chamber. Here you see that the surgeon is using the main wound for the infusion. That creates a lot of fluctuations in the chamber, and the vitreous then tends to move forward. You see this leaky wound. Instead, always make a side port and see this. You can suture the main wound if you want. So it's always through the side port. Through one port you put the cutter, through one you put the infusion, and then do your anterior vitrectomy in a closed chamber. Always respect the vitreous base. So the way the PCT is managed, the outcomes always depend on the way the vitreous has been handled. So please respect the vitreous base. Do not do such maneuvers as cutting with scissors, pulling, or drawing at it with sponges. Because as you see in the lower picture, the small little tear that can be induced can cause a retinal detachment a few months or years later. This very small tear at the vitreous base. What I would suggest is to do a pars plana vitrectomy. It gives you a more, you can clear up the vitreous thoroughly, you can remove the pieces, it reduces the vitreoretinal traction, it provides a better endpoint, and it gives you better access to the remaining lens material. It also preserves the capsular support. So you can go in through the pars plana. With an MVR blade, you make these incisions. It's an easy technique to learn. And then through the pars plana, you put in your instruments and then remove the remaining cortical matter and do a vitrectomy at the same time. The appropriate nucleus management, in case a small piece is left, that is around 1/4, you can get it in above the iris and continue your phaco after putting in a lot of viscoelastic to stabilize the chamber. In case there's more than half the nucleus, you can enlarge the incision and then remove it. Various techniques have been described, foremost being the chopstick technique, wherein you use two instruments to get a hold on those the nuclear fragment and remove it. And if there's a nucleus drop, it is best left to the vitreoretinal surgeon. Another good technique is the IOL scaffold technique. So I'll be just showing you a small video of that. This is a PCT that has occurred, and this is the nuclear matter that is left, which is being removed, as I said, with two instruments. This is called the chopstick technique. Herein, you can insert the IOL. You go behind these nuclear pieces and you can put in your IOL. So that way you have something in between the vitreous and your pieces, and there is less likelihood of these pieces falling into the vitreous. So the IOL is inserted first, and then the remainder of the pieces are removed. So this is the IOL scaffold technique, which is also a good technique to learn in some cases. And then once you put the IOL in the sulcus, you can remove the rest of the nuclear material. If soft lens matter is present in the anterior chamber, it can be removed with the suction mode of the cutter after doing a proper anterior vitrectomy. So the cutter itself is being used to remove this soft matter. So get it into the central area and then use the suction mode of the cutter to remove this soft matter. Whenever there's a dropped nucleus, it is a very, very dire complication for the cataract surgeon, but it's a fairly straightforward problem for the vitreoretinal surgeon to solve. And the dropped nucleus cases referred to the retinal surgeons are into two categories, that is initially well managed by the cataract surgeon and poorly managed. So as we all know, don't fish, don't chase after the falling nuclear fragments, avoid any unnecessary manipulations in order to avoid vitreous traction and the consequent retinal detachments and CMEs. So do a thorough anterior vitrectomy and ensure there is no vitreous in the wound. If the required instrumentations are not available, then leave it to the posterior segment surgeon to do it. It is important that you retain a good capsular support. And if you find that it's difficult to clear the residual lens matter, then again leave it to the posterior segment surgeon to manage. As regards IOL placement, implant the IOL only if you feel that it's stable. This is all in cases of a dropped nucleus. So if you feel the IOL will be stable, only then you implant it. If it is questionable, then do not. And an ACIL should be implanted if you've had a dropped nucleus. Now for the cataract surgeon, what you can do is you can implant an IOL in case there's a dropped nucleus. After that, remember to constrict the pupil and then stain with tricot to see for any residual vitreous in the anterior chamber. And in case there is any vitreous, then do a vitrectomy to clear it. So tricot comes in very handy. Wound closure is extremely important when you have a dropped nucleus. So ensure that you've closed the wound properly. Every cataract surgeon should have an arrangement with a vitreoretinal surgeon to refer these cases. I'm a vitreoretinal surgeon, so the information that I would want from a cataract surgeon are all these: that what was the amount and type of the lens matter, what were the maneuvers performed, the hardness of the lens, the presence of an intraocular lens, the amount of capsular support, and the IOL power. So my last slide, the management of a dropped nucleus can be done in the same sitting if you have an in-house vitreoretinal surgeon, but there is no need to panic. Many studies have shown that the visual outcomes are the same in a case whether it is operated in the same sitting or even if you defer the surgery for 2 weeks, provided you control the inflammation, the intraocular pressure. The management is just the same, so there's no need to panic. You just close the case and refer it to the vitreoretinal surgeon to take care of. So to end, do not panic. Whenever you have a PCT, do not panic and withdraw the probe. Inject high molecular weight viscoelastics. Reduce the bottle height. Do the appropriate nucleus management. A thorough bimanual anterior vitrectomy. Place the IOL appropriately. Do not chase the nuclear fragments. And a vitreoretinal consultation can often resolve a dropped nucleus with minimal morbidity and excellent visual outcomes. So PCR, if managed appropriately, can give you very good results. Thank you.
Thank you, Dr. Tinku. Now we still have 10 minutes to go. If there's any question from the audience, we'll be happy to take that questions. Otherwise, I'll ask the speaker, I'll ask the question from the speakers. Dr. Ikeda, what do you think is the main reason why you feel the PCR is more common in a softer cataract, particularly in a learning stages?
So when we are dealing with soft cataracts, the problem that we face, often we say softer cataracts can be a harder job than hard cataracts, especially where we are starting out with cataract surgery. And the reason why this happens is that we find it very difficult to hold the nucleus. We tend to operate at lower vacuum settings, and this makes it difficult for us to hold the nucleus. As it is, the nucleus density is very less, and therefore when we are unable to hold the nucleus, we are unable to chop it effectively, and this leads to a tendency where we are trying to grab the nucleus in the peripheral zone, or we are trying to chop in the peripheral unsafe zone. And this in turn leads to inadvertently us either catching on to the posterior capsule or catching on to the rhexis margin, and which in turn would lead to these drastic outcomes of us causing a PCR. And the second problem that occurs is when we are trying to chop and we are unable to chop, it leads to formation of a bowl, like I demonstrated in one of the cases. So we have tried again and again to hold on to the nucleus, and what happens is that we just end up splicing through. In our phaco probe, the nucleus, a part of the nucleus which just keeps coming in, and we don't end up holding it, but we end up splicing through. And then we have to deal with this bowl, and again we have to go to the periphery to get rid of this central bowl that we have created and to emulsify. So this is the second reason why I feel that it leads to a higher chance of PCR.
Other removal of the anterior nuclear plate between the nucleus and a rhexis margin, is there any problem in removing that? Is there any chances of tearing the capsule if you do that?
Yeah, so the next, once we have dealt with the nucleus, the second aspect is to remove the epinuclear plate that is left behind. And again, epinuclear plate can be a little sticky, can be stuck to the cortex, and we can have issues in removing the epinuclear plate as such. So for that, we have a couple of options that what we can do if we are stuck in such a situation. What I personally like to do is either inject a little bit of viscoelastic behind the epinuclear plate if we are unable to pull it out and emulsify it, which helps in prolapsing the epinuclear plate a little up, and then we can emulsify it safely. We can use a dumbbell diarer or a blunt instrument like an iris repositor instead of using a chopper to rotate the epinuclear plate, which would again help us. And thirdly, if we feel that the epinuclear plate we are not being able to prolapse it, then we can even use, after removing the nucleus, we can go ahead with a hydrodissection cannula and do a little bit of hydrodissection, which will loosen up the epinuclear plate, and then again it will make it easy for us to emulsify it.
Thank
One
you.
of the
Dr.
thing-
Rajiv Chaudhary,
Yeah.
we'll come to the. Just
No, on the soft cataract.
So now I'll ask Dr. Ashok Sharaf. In an intumescent cataract, have you ever tried the lens massage? Lenticular massage?
No, sir.
No, I mean, because there are fluid pockets in this soft cataract, intumescent cataract. So what I started doing is do the massaging of the anterior lens surface, so those fluid pockets are broken. And in fact, the fluid goes into the periphery, and you can call it donut capsular excess. So that virtually prevents the runoff of the capsular excess. You can do the routine.
Thank you.
So in an all white cataract where you find different pockets of fluid, you can see the crystal small dots and crescent, radiating white pockets. You just do the lens massage and the capsule will become soft and you can remove it.
Thank you.
And Dr. Anurag, do you think, I mean, what type of the pupil size where you will feel that we need to use the expander, or you can manage without using the expander?
So there is absolutely no magic figure to that. I can't express that in numericals. It actually depends on the surgeon's comfort, and obviously the nucleus hardness will also play a role. What we're looking at is a 4.5 to 4.7 millimeters rhexis. So we could imagine that if the pupil size is anything more than 4 or at 4 also, you can just go beyond the pupillary margin and enlarge the whole capsule to produce a 4.5 millimeters rhexis approximately. So 4 is where I would have my cutoff. If it's less than 4, perhaps, and if it's a nuclear grading of grade 3 or more, then I would be very tempted to dilate the pupil with a device. Or if the eye is precious, like it's a one-eyed patient or it's a very high myope, then perhaps I would also be tempted to dilate the pupil. Otherwise, 90% of the time, with a 4 millimeters of the pupil size, I would not be very keen to dilate the pupil, because these mechanical instruments actually produce microsphincter tears, and then these patients do come back to us with a little bit of disturbing photophobia once they're exposed to sunlight post-operatively. They lose their elasticity, they lose their ability to control the light the amount of light that's entering the eye post-operatively. So I'll be far away from using the devices as much as possible. However, wherever it is required, then I'll not shy away.
I think I agree with you, and the only thing is that at times probably not doing hydro may help, because when you do the hydro, pupil suddenly becomes small.
Snaps,
so there may be certain situation like a small pupil, shallow chamber, a very hard cataract before doing trenching, and a posterior polar cataract where you can actually avoid the hydrodissection and proceed. Yes, sir, you wanted to say something? And meanwhile, ask Dr. Rajiv Chaudhary. Would you like to elaborate what is the difference between the capsular hook and a
So there's a
iris hook?
microphone.
Okay.
I have a question for Dr. Anurag. When you were doing synucleus, there was a lot of pull towards the peripheral part of the iris. So, in some inexperienced hand, he or she may land into the trouble of iododialysis. So, why not to prefer doing synucleus with simpler instruments like iris repositor, or if it is too strong a synecia, we can even cut it with instruments like Vana Caesar and all that, rather than pulling a lot of stress over the peripheral part of the iris, and one may land into the problem of iododialysis.
The synecholysis should always be done with a repositor, sir. What I was demonstrating was not synecholysis. I was actually trying to pull off the membrane. You're right, you can also cut it with a Vanas or any sharp instrument, but it will essentially give you the pupil back, but what it will not do is to ensure that it dilates to its fullest. So to to completely negate the restraining factor I was trying to peel the membrane off. So you're right that it produces a stress on the iris root, and at times it might cause a ciliary body bleed. So you have to be careful how much of pull you can be doing or you should be doing. What I have also attempted at times, due to shortage of time, I could not show that, is to hold the pupillary margin of the iris with a second instrument and produce a counter traction, so that you essentially actually rip it apart with the help of two instruments moving in opposite directions. That also reduces the stress on the iris root. So that can also work for you. But in the end, I would always recommend to rip off the membrane rather than cutting it, because that ensures that the dilatation is to its fullest and it brings back the geometry and the maximum size possible thereby.
Actually, initially it was a very good idea and ripping off, but now with the availability of the dilator, if you feel not so comfortable, actually you can leave it. Initially, because when the dilators were not available, just ripping off the membrane and using the viscoelastic to dilate the people, we could do the phacoemulsification. So now Dr. Rajiv, yeah.
He is want to.
Again, a question to Dr. Anurag. In a small people, what's the size of the capsular axis you would prefer?
I always prefer a size of 4.6, 4.7. I used to go up to 5 previously, but after I got the femto machine installed, it stays with a 4.7. Sir, I'm very used to a 4.7 now. 4.6, 4.7, that's the max.
Okay. Just, I wanted to tell one thing. The larger the capsular axis, it becomes easier for the process of phaco. And next step is, it has to be a vertical chop.
So actually rexis size will also depend upon the density of the nucleus. Usually if the nucleus is not so hard, I mean, so these, of course, the post-uveitic cataract are very soft. So you really don't need very large rexis, more than 4.5 in any case. So only if it is a very hard cataract, probably you need it.
Thank you.
Dr. Rajiv Chaudhary. The difference between
the iris hook and capsular hook is the angulation at the junction, because that iris hook is straight and the tip of that hook is slightly rounded, so it will not injure the capsule. So that is important. It will hold in the direction of the jonules.
So the capsular hook basically try to give a pressure at the equator of the capsule, not at the margin. While if you use the iris hook, you pull at the margin, because the capsular hooks are little longer. So if you have a capsular hook, it is better to use them in cases of subluxated cataract than iris hook.
One of the point I want to add in the soft cataract is that if you do the hydrodissection and good, because the soft, we are also soft not to do the hydrodissection, and if we rotate so many times, it will remove your epinuclear plate and it will come, because once it is soft and you do the phaco, the phaco will be so vigorous that you will leave with the posterior plate. So if we rotate it fast so many times, it will remove your epinuclear plate.
And you can actually use irrigation aspiration cannula to remove the epinucleus plate in a soft cataract very comfortably. And the trick over there is, try not to remove the epinuclear plate, remove the cortical fibers. Once you remove the cortical fibers which are lying at the periphery, epinuclear plate automatically gets detached.
In that case, the small people, I would prefer capsule care over the iris retractors, because the iris retractors, when you retract the iris, the peripheral iris goes very close to the endothelium. So any entry or exit of the instrument will traumatize the iris. While in capsule care, there is a little gap between the peripheral iris, most peripheral part, and the endothelium. So the trauma to the iris is less.
The capsular hooks actually are designed to suspend something. They're not designed to pull them to the periphery. So
no, sir. But then I have been using it. Very good.
You can use it. You can use it.
In my hand, yeah, it's very good.
You can use it, but yeah. So
I think with this we come to the end of the session. I thank all my speakers.
Can I excuse me? Can I put a point if it's possible? Yeah. So what I have been listening is that we should have a smaller axis or just enough axis in posterior polar cataract. What my experience is and what I study about the biodynamics, the entry and the posterior compartment where the space, intracapsular space and the extracapsular space has to have a minimal pressure difference. So what I follow is that when you have a posterior polar cataract, the capsular axis should be larger. Why? Because when you are going to do any hydrodelamination procedure or whatever procedure that you are going to do intracapsularly, the pressure difference between the part that is outside the capsule and in the intracapsular part has to be minimal, and this is one of the most important part that will avoid the dehiscence of the posterior capsule. But if you have a smaller axis and if you are doing maneuvers inside the capsule, the chances of a posterior capsule getting torn in a posterior polar cataract is much higher. And rather than having a larger axis and you are being afraid that we cannot manipulate later on, but if you even have a posterior capsular dehiscence in a larger capsular axis, then it is possible to manage it better rather than having a smaller capsular axis and a posterior capsular dehiscence, because then the cortical matter cannot be easily removed. So for me, it should be a larger capsular axis than a normal in case of a posterior polar cataract, so that you are preventing a posterior capsular dehiscence, and in case of a posterior capsular dehiscence, you have a capacity to remove the cortex easily and manage it better.
See, I think our time is up, but just one line I will add, that when we say larger, it should not be more than 5.5, because now we want to have the good, many of them go for a multifocal IOLs. You want a good centration of the IOL. Yes. If it is more than 5.5, just there is no point of discussion. I can come down, we can discuss. So if it is more than 5.5, then the chances of decentration of the IOL are far more as compared to, so whenever we say the axis large or small, for me the range is between 4.5 to 5.5. 4 less than 4.5 is not adequate, more than 5.5 is not good for centration of the IOL. Thank you very much, and we come to the end of this session.